special indications. There is one which is really going to increase and increase, which is the indications and the discussion of presbyopic IOLs after refractive surgery. So how do you deal with that? Is there more EDOFs that may find a place before, because as we mentioned, they are more forgiving of some remaining errors. So what do you think about that?
I'm still pretty conservative in this way, I must honestly admit.
But these patients are very demanding.
I know, but that's one of the reasons why I'm quite conservative. I mean, you have to educate them even more than regarding their expectations and so on. And, well, looking for lenses that can tolerate this more. Probably we know that there are new types of lenses now coming on the market which can give you probably good distance vision, but also some intermediate vision without having optical complaints issues or having a lower incidence of that. So, I mean, that would probably be my preferred choice for these patients.
Well, I think, unfortunately or fortunately, those patients who had refractive surgery are the patients who wanted to be spectacle independent. Yeah. And now they come for the lens surgery and they expect the same thing. And then we try to find a solution. I have to say, refractive surgery is not refractive surgery. It's a big difference between a patient who has -1 LASIK than an 8- LASIK, because you have a totally aberrated cornea. Yeah. And though in the low amounts, I have found myself using now trifocal lenses, but they have to be low amounts. Otherwise, I would always go for depth of focus because of the reason Oliver pointed. They are more forgiving. You get that. But with this, we found we have very good outcomes so far. Not yet a study, but we want to look at this. So I think here is a really good indication for the depth of focus IOLs. And again, here we have actually 4 different depths of focus concepts already. Yeah, so there will be more opportunities. Very soon we will have a non-diffractive aspheric IOL. We have at the moment diffractive, and the other, like the pinhole effects. And so there are many opportunities for us to look at this. Aberrated corneas are very good, or will be an indication for depth of focus IOLs.
I do agree.
What is your preferred way of treating the residual errors then in these patients?
Yeah, that's a good point. If for example, let's say the patient had been 10 years ago from us LASIK, and I knew the procedure I had done, I'm happy to lift the flap and do another refractive surgery. Basically, in eczema is usually low amounts because the formula is getting better, because we have all now formulas who going in this direction, actually aiming for this post-refractive eyes. But there are also possibilities, if we don't know them, we can do surface ablation. And we also have started to use low amounts of add-on technologies. You can have add-on technologies to do basically take 1 diopter additional and add-on IOL. So I think there are several options, but you have to explain this to the patient. And this is even more work, because now you come into this and these patients say, okay, I had refractive surgery, now I go there, just take me a lens and then it's done. But no, this is really time consuming to talk to them.
Oliver, can you say a few words about these new categories of advanced monofocal that will certainly occur very soon in the market, as I would say a compromise between EDOF and monofocal?
Yeah, I mean, I think it's a concept of having a monofocal lens and just changing slightly the anterior contour and essentially having a slightly higher power in the center, but not like a ring. It's not diffractive. It's not a classical refractive, but it's a continuous change. What it does is the defocus curve is a little broader. You will lose a little, very little in distance acuity, in best distance acuity, which is probably not so relevant for most patients, I would say. And what you have is a slightly larger sweet spot for your refractive outcome. That means even if you're half a diopter off 0, the patients still have very good unaided acuity. You don't have dysphotopsia, and you wouldn't expect it. And I believe also contrast sensitivity, at least from the lab data, looks exactly the same. So I think that's a new option. It sort of tries to push in, as you said, between monofocal and EDOF. I think it's a little too early to say. I mean, we only have experience since a few months. But I think it's something which is, I think it just gives you a better sweet spot. And if you hit exact emmetropia, just by luck, let me say, then you have a little intermediate vision. So I think it's from my perspective a concept where you shouldn't actually tell the patient really about it, to be quite honest. I wouldn't make any hopes, because if they had hopes, then they obviously think about intermediate vision and they may not need glasses very often. I think you shouldn't do that. I think you should say this is a monofocal, new monofocal lens, and ideally you have just slightly better outcomes, which would be obviously great.
Do you think that that may be a new door that will be open to enlarge, I would say, especially to the surgeon who are not very attracted and convinced by this quite difficult, because we understood that many factors needs to be taken account. Do you think that might be a way to, again, make the community more sensitive to this progress in optics?
Yeah, I mean, I'm not, but the community, I'm not so sure, but because I don't talk about it. So actually, what I've done is I've taken my monofocal lens back and I have replaced it completely with this lens, which has these aspects we just spoke about, and we're using it as a monofocal lens now, and we're again not promising anything, and hoping that we will deliver at least some better outcomes. So that's my take on it. I mean, I think we need obviously now larger studies to really look at that in detail. But I think it's a very, very low risk situation. Essentially, it's no risk from my perspective.
I think that's very important. The low risk, if you look at our fellow surgeons in my country at least, the market penetration of presbyopia-correcting lenses have been quite stable over the years, don't go up. And one of the biggest drivers there is still the optical complaints that people can have and that you cannot predict in some of these cases. And that makes surgeons a little bit reluctant to use. If you have on the other side something that can promise you or give you a little bit more in terms of outcome performance, while not having complaints, I think that's a very good idea.
What about your opinion, Thomas? Do you think that why we cannot go more than 7% in the best case, but even 4% for the global market scope in the world? Yeah. Do you think that it's the key explanation there?
Well, overall, I think that the discussion we just had has shown that it's not an easy thing to do this, and obviously it takes time, and so maybe that's one reason. There are several other reasons. The IOL Oliver described, I think, is another way to broaden the spectrum. And when I came from the trifocal, and we started first a trifocal and then added depth of focus IOL, but that enlarged my scale of presbyopia. So if the next lens, which comes from a monofocal and maybe can do a little bit even more there, then this would broaden this spectrum again. In Germany, all these lenses would be considered to be premium IOLs, so they have to be a co-payment because they are not in the normal standard of care. But I think it will be another addition. Now, having said this, it becomes more complicated for all of us because we have to, select more and more. But that's also nice because we actually have the opportunity to help our patients in various situations now.